All right, everybody. Well, welcome back to Stand By for Tones podcast. Once again, you got Isaac and Sam with you tonight.
Hello, hello.
What are we doing today, Sam?
Oh, Isaac, we got a lot of things on the docket for today.
Awesome.
You know, the first thing that I want to remind everybody about is that you can find all of our stuff available online on our website, standbyfortones.com. Check out the book, check out the flight log, check out our courses. And if you're listening to this, share it out to your friends so we can, continue doing these fun things that we do.
Absolutely.
Right? So, we work for some pretty cool people.
Agreed.
And we do a lot of cool things, and there's a lot of cool things that come out of other states. And we have a case that I want to review.
Okay.
And not necessarily we're going to review it, but we're going to review some of the things that were brought to our attention just kind of at a national standard more than anything. And the first thing I want to go over is, what do we expect out of our EMS partner? Whether it's a nurse, we'll go down to paramedic, EMT, like what makes a cohesive team? Because there's a lot that goes into it. And we both have had, run-ins with partners before. And that just comes with the territory of working with somebody for 24 hours at a time for a year or more with the same person.
Oh, yeah, absolutely.
It just kind of comes with it and comes with the job. So when I say your partner, what are you looking for?
Ooh. Tough question.
It is, but I mean, like,
for me, I don't know. Someone that I can just relate with for the most part. I mean, as far as, I feel like for the most part, depends on what you're talking. So if we're talking ambulance, EMT wise, I mean, I want somebody who's, again, I can get along with, have something in common. Mm-hmm. If we're not busy, we can talk or we can be silent, and it's not a big deal. All right.
Yeah. Pick a common show to hang out and watch, the stuff.
For sure. And then when it comes to actually running calls or doing something like that.
Yeah.
For me, with my EMT, I mean, I want them thinking ahead of me.
Yeah. You want them to be dialed, right?
Oh, for sure.
We have to remember that takes time because the era of EMS is getting younger and younger. Ooh. There are a lot of people coming straight out of high school and getting jobs with, these big EMS agencies like AMR, our local agencies. They're getting out of high school as EMS professionals, and they have no idea what they're getting into.
No.
And then they're put either with a new paramedic, and you just kind of watch the slight dysfunction. So, when I think about it, it's like you said, somebody that's thinking ahead of you a little bit, like not necessarily the same thought process, but like, this patient's going to need a 4 lead. This patient's probably going to need a 12 lead. If they say the magic words of chest pain or altered mental status, that should already ring a bell that, this is going to be an ALS level patient, right?
Correct. Yeah. I want them thinking ahead and be able to think for themselves.
Yeah.
Know that, again, we're going to be doing an IV. I don't need to tell you to set up an IV stuff.
Mm-hmm.
But
or even go get it started. I mean, like we work with a lot of EMTs with optional modules. Like, we're going to need it, just start it.
Yeah.
It's going to be okay. I'm not going to yell at you.
I do laugh about the coming out of high school and all that stuff like that. Like I do feel bad for the people who had to put up with me when I first started, right? Because when I started, I mean, they almost didn't think they could hire me because I wasn't 21 yet.
Yeah.
So the insurance didn't want to cover me. So I was working with all these, again, seasoned professionals. And I'm 20 years old, have no idea about life.
Mm-hmm.
So I do feel bad for them. So thank you if you're listening to this.
Thank
you know who I am, and you had to put up with me. I appreciate you.
I mean, I was an 18-year-old still in high school when I started my first fire job and on the ambulance. Like it was brutal. Like, I feel bad for them. Okay, so that's your first thing. So, like, somebody that'll think with you. You can bounce ideas off of, think a little bit ahead. Like, let's get to like the 3 level. Like what are your top 3? So we got your first one.
For sure. I want somebody who's not afraid to say something as well, right? To be able to be like, hey, what do you think about this?
Mm-hmm.
Right?
Somebody that's got a voice,
if I have
right?
some idea running through my head, and sometimes we get tunnel vision. So it's nice having someone there to pull you out of that and be like, hey, focus on this, or what about this instead? Even if it's just moving a patient.
Yeah.
Right. That's something we do every single patient is you got to move them from point A to point B.
Yeah.
And then point B to point hospital bed.
Yeah.
Right. So you always have to move somebody. So even something simple as that, having good ideas for how are we going to move these guys without hurting them, without hurting ourselves.
Yeah.
And not being dead by the time we get them to the stretcher or out to the ambulance as well. So just somebody who's able to think for themselves and not afraid to say something.
Yeah.
Or ask questions.
Okay. So we got, having a little bit of a forward momentum, someone that can think for themselves. What's your hallmark? If you were to lose both of those things, what do you got?
Somebody that can drive. For me, I was
especially
horrible.
right now, man.
I hated driving. Well, yeah, right now, wintertime.
Yeah, we've got
Dealing
6
with all
inches
this-
or over 12 inches of fresh snow out there.
Oh, yeah. That I don't mind driving in the snow. I like having fun.
Yeah.
But just knowing that I'm going to get to the call or get to the hospital safely is great.
Yeah.
But, yeah, somebody who's willing to drive a lot,
Yeah.
I can't tell you how many times I've been like, hey, if you drive, I'll take this patient. Like, it's BLS. I'll write the chart.
As long as I don't have to
I don't
drive
have
the
to
2-hour drive.
Like, I'm good.
Yeah.
So
No,
I mean,
I like that.
That's simple, but it is something that is important.
Yeah, it changes the dynamic of the day,
It
right?
does.
Like if you have to do all the patient care, all the driving, all the paperwork, it gets task saturated really fast. So
yes, it does.
yeah, I think we're really lucky with the providers we get to work with, because we work with some pretty high functioning EMS providers, all the way from the EMR to the paramedic and above, side of things. But what about your nurses? Like,
Oh gosh. So that's a whole completely different dynamic right now. Talking about working critical care and working with a nurse, it's kind of it's totally different, right? Going from when you're on a truck with an EMT and it's you two, you're in charge of that truck. Everything comes back on you. It's your truck.
Yeah.
Let's be honest. But
it's your license and your medical director's license on the line at all times. And
so now changing that role to now you have a very high level provider and a nurse who has come from a completely different world than you.
Yeah.
Well, first of all, I love it.
It's probably the best thing ever.
It is. And you can learn a stupid amount from your partner.
The people we used to argue with in the ER all the time.
That is very true.
Yeah.
Well, and honestly, my favorite nurses don't come from the ER. Sorry, ER nurses.
ICU for
ICU
life, man.
Or some sort of critical care specialty.
Yeah.
Doing trauma services, doing burns, doing whatever it is.
Yeah.
And especially that ICU care, so important for flight nurses, because you get to bring that whole dynamic to the team, right?
Mm-hmm.
So, we deal with emergency stuff. We know what ER room stuff's like, but having somebody that you're taking off the floor with 7 drips going and looking at their labs and being able to interpret that kind of stuff is right up critical care nurses. That's their lane.
Yeah,
so
we pick it up as we go and do these things, but
we do.
They get to bring it to us. Just it's a cohesive nature, right? We bring our side of the story, they bring their side, we meet in the middle, and we work well together.
Absolutely. That's what's important, is being able to work well together. I've been crazy blessed with my partner, my nurse, who's insane. Love her to death.
Oh, yeah.
She's, I learn something new every single day, and she makes sure I learn something new every day, which I love, that she's not afraid to, teachable moment all the time.
Yeah.
So
I had one shift with her. Good Lord. It was good, though, man.
Yeah. Oh, yeah. So as far as me, I absolutely love being able to work with a nurse, being that high level thinking all the time, being able to help out with the charting.
Mm-hmm.
I feel like I'm always just trying to hold on, slow down, let me do some of that too. I want to help out. And that's something for us to too, when you get into that role, when you get into critical care medicine is making sure that you're covering your side as well.
Yeah.
Make sure you're
Shared
stepping
responsibilities,
up to the plate,
right?
not letting them do all the charting, not letting them do all the work, even though there's always feel like the biggest argument is, well, they get paid more, they should do this. Well, no. I mean, you guys, it doesn't matter. Yeah, they get paid more. They're nurses. Get over it. Unfortunately,
they went to school a lot longer than I did.
We'll never be on their level just because their group has done so good.
Yeah.
And we're classed completely different, right?
Mm-hmm.
So, unfortunately for us, the money will never be as good. But that doesn't mean that you don't need to hold up your end. You have to actually hold up your end of of patient care, of charting, all the stuff, thought processes. And that's one of the biggest things I think for critical care paramedics is making sure you're up in your game. You're not just on the truck anymore. It's not just playbook stuff.
It's not an ambulance with wings.
That's right. I mean, we do have our own driver, which is amazing.
Yes, that is probably one of the best parts. I mean, next to the nurse paramedic relationship, I mean, like having that fresh person to come in every day that's their sole responsibility is our safety. Yeah. Is like the biggest relief ever.
It is. It's nice having a pilot, but no, for me, I want to make sure that I'm not the weak link. Yeah. I want to make sure I'm bringing something to the table. So, staying up on education. Yeah. I mean, and studying hard.
Yeah. Do you think they do better than us on staying up on education, just as a profession in general?
I'm not sure.
I think we have the availability of it more, and it's more readily produced to us.
It might be. I feel like for us, I know it has been for me for a long time. Mm-hmm. At least it used to be. It's like education was something that we had to do. It's not something that we like to do or something that is actually useful. A lot of times it's like, okay, click next, get through this thing and be done with it.
CTS every month.
Right. Yeah, CTS, oh my gosh. But no, so I think for a long time, I mean, I've hated EMS education, as you know. That's why we're here.
Exactly.
But no, that's something that you need to bring as a critical care medic, and that's why, again, you should have 5 years at least. Mm-hmm. That's probably not long enough, to be honest. But hey, for some people it works. I get it.
Do you think that 5 years needs to encompass like an RSI service, or do you think that's an on-the-job training skill these days?
It would be nice, but it's never going to happen for everybody, right? Not everyone's been fortunate to have those kind of protocols, that kind of service, stuff like that.
Yeah, sometimes it's just the state that restricts it, right? Like,
it is. It can be.
I just got back from teaching in Montana, and I learned a titch of information about the Montana EMS system is that no ground paramedic, no matter what service they work for in the state of Montana, can RSI unless they are in a helicopter as a flight critical care provider, which is hard because they're remote, right?
Very.
They have some crazy distances that they cover, some crazy areas that they cover. But I mean, like, they do have some saturation of air ambulance agencies and things like that. But I mean, like, there's days where we can't fly.
Oh, yeah, for sure.
Like, and then
there's days nobody can fly around you.
Yeah. So it's those crazy little things that we think about, but barring the, ICU experience, the education, all that stuff, like, what makes you excited about coming to work with your nurse? Like, what is it that they look for that they'll bring to the table for you to do your job successful?
Again, I think it's just that different knowledge base that they have dealing with critical care medicine, strips, all these, stroke medicine, stuff like that dealing with hypertension. Like, I mean, we would deal with hypertension every once in a while, but that's something that they have strict orders that, like, this patient's blood pressure has to stay between this and this. Yep. So they're pulling out, they know 5 different medications that can get them there. Yeah. They're going to follow, obviously, their protocols in the ICU and doctor's orders, but there's something that they're used to and they know those drips. Yeah. Something that we don't get to do a whole lot of, coming from, the nursing home or wherever it is to the hospital. For the most part, we're not starting all those medications because we don't know the diagnosis. So it's hard to, obviously you're going to call if you need to or follow your protocols as far as parameters go, but they have way more availability of that stuff, and they see so many more critical care medicines, and even just how that patient's going to progress throughout the hospital system, whether it's coming from surgery to the ICU, back to surgery, back to the ICU, move into long-term facility stuff. I mean, they understand all of that stuff, something that we don't get to deal with. So
kind of more of a specialized or a specialty. They come from that specialty realm. They may have bounced around from the hospital from time to time and pick different floors or resource nursing or something like that. But most of the time, they usually stick put pretty well. Like, they get to have that experience either in neuro ICU or CV ICU, or, they're with a perfusion team, and they can really bring everything to that table. And I think what I'm trying to get here is that everybody has their own take on what their perfect partner is, and it's never going to be perfect, right? I've had I've had partners that I absolutely love working with, but then we'll have a week where we just don't get along, and you have this pissing match between you and them, and then you patch it up like your besties again, and you just had to, strangle each other for a minute, and that just happens. Oh, it's part of the job, right?
It does. I mean, it's a relationship that you have to always keep working on. Yeah. Right. And it's something that is difficult.
Yeah. And it's a constant give and take. Like, it's just like any other relationship, whether it's at home or at work or anything like that. These people become your family in essence. And, you have to learn what your version of a good partner is, and then just kind of roll with it. And don't be afraid to have these conversations with your partner if you need them to do something different, because we're all in this as a team to learn and bring our knowledge up, which is why we're going to segue into something that we've been kind of holding near and dear to our hearts most recently, just on the fact of that we are pretty terrible at resuscitation when it comes down to treating our patients, not like cardiac resuscitation, but hemodynamic resuscitation prior to intubation. So we got a case where elderly female found down in a house, has the gurgling, the gurgle of death, and they get there, find her, GCS3, blown pupil, and, this lady is found down, right? I think as providers, we get in this rut where everything is so rushed, but we forget about some of the basics. And those are the easiest things that we can manipulate without going over the realm of impossible prior to getting to our intubation attempt, right?
Yeah.
So this patient was found with really piss poor vital signs, like blood pressures in the 70s, blood pressures in the 60s. So one of the things I have to remember, and we're going to kind of segue into some TBI, spontaneous head bleed stuff, just kind of a neuro kind of case. Because, this patient had a blown pupil. There's a bunch of different causes for that. But first one that comes off the top of my head is some form of neurological insult. And the things that we have to avoid is that the 3 H bombs. I don't know if you guys know about the EPIC head bleed style. If you want to look them up, it's the EPIC TBI study. They just released the 2.0. And EPIC for kids, which we'll cover at some other point, but it's a really good study that shows how these 3 important things can really improve our patient outcome, and that's preventing hypotension, preventing hypoxia, and preventing hyperventilation or hypocapnia, right? As Correct. We kind of get into more things. And there's a whole lot of things that go through this, but there's about 130 agencies in the state of Arizona that participated in this. It's one of the biggest EMS studies that has ever taken place. And it showed that we can double our chances of survival just by preventing those 3 things. And we can prevent those 3 things with a BVM, right? So having good BVM techniques and all these other things. And then it showed that it not only doubles their chances of survival in kids, but it brings it up to a 700% chance of an increase to survival in kids if you can prevent those 3 things.
Wow.
It's huge, man.
It's huge.
It's huge. It gives me goosebumps. And this study's been around forever. Well, not forever, but I think it happened between the 2007, 2012 range in that couple years. And the biggest thing that we overlook before our intubation attempts is that stable vital signs, right? We need to get that blood pressure up. We need to get these things because the initial insult's already been taken care of, right? They already had that traumatic brain injury. They already had that spontaneous head bleed. We can't fix that.
Correct.
That's a neurology thing. What we can prevent is what we call the secondary brain injury, and we need to really be able to focus in on those things. So, optimizing your game in resuscitation is huge. I mean, like, one episode of hypotension, if they're normotensive after that, it does some ridiculous number, like increases their mortality by like 300%, right? So it's like we have to really be on top of these things. So back to that kind of case study, some of the vital signs that reported to us, I mean, like, came into the hospital with vital signs in the 60s systolic and slightly tachycardic and, was hypoxic and, I mean, like, all of the things that,
all the bad
jujus.
Yeah,
all the bad jujus. So, like, how do we get it across to people to, prioritize on the resuscitation game?
That's a hard question, because it's, unfortunately, a lot of times seems like that's secondary in our mind, if not tertiary, right? Because you're worrying about you gotta get that airway secured, and just even, like I said, you have, every single time you see a patient, you have to move them. So I mean, you got to get them out of whatever closet or bathroom or bedroom or wherever they're at.
Yeah,
because it's never perfect. It's never in a nice open area, right?
No.
So being able to actually get them to your ambulance is always a priority, and something that we're having to think about. Something I think about every single time. How am I going to move this person?
Yeah.
But then again, now you're worrying about airway. You're worrying about getting an IV so you can even get any of this stuff done. Yeah. If not, going to an IO. So unfortunately, it gets bumped down that list, and it's something to easily kind of just go out of our head and not think about it until you're halfway to the hospital and go, oh, wow, yeah, their pressure sucks. We should probably work on that, right?
But I mean, like, as providers in general, do you feel like we're missing an opportunity to utilize the patient's home or where they lie technique in their procedure move? Like, we're going to crash their pressures by moving them. We're going to crash their pressures with RSI induction and paralytics. Like, are we missing a vital window by not treating them? I mean, like,
absolutely. And I think you talked a little bit, or you mentioned it in the beginning, about how, I mean, you have this timeline that you're supposed to meet. You've got the golden hour. You've got only 10, 15 minutes that you're supposed to be on scene. It's a TSE type of scenario. You need to get them to the hospital quickly. But in reality, are we actually doing any good for our patients by focusing on getting them out of there quickly and letting all the H-bombs take place versus, you know what, I don't care. We're going to spend 20 minutes here and get more stuff done. We're going to resuscitate them first.
Yeah.
Instead of, again, just trying to get everything done as fast as you can and get them into the hospital.
Yeah. I mean, like, that vital window of being able to come in and, find them as they lie, because there's not a lot of providers that get that opportunity.
Correct.
And I feel like this was one of those situations where that opportunity was missed for the comfort of ourself, right? I mean, like, I get it. Like, if it's a straight shot out the door, there's no hallways to go through, they're laying in the middle of the kitchen, like, they're easily accessible. But sometimes we have to do the due diligence of putting ourselves out of our comfort zone to treat them before these big, procedures, like whether it's intubation, i-gel placement, all those things are going to cause some form of hemodynamic instability. What's your goal and your game plan when it comes down to, pre-procedure hypotension? Do you have something mixed up all the time? Do you have, like, your A, B, and C of what you're going to do for your pressors? You're going to do push dose, anything like that?
I got you. There's a lot of times that we have push dose pulled up, ready to go.
Yeah.
I don't know how many shifts I've walked around with a 100 ml bag of push dose epi in my pocket for the whole shift. I don't think
there's not a lot of people out there that know about the 100 ml bag trick.
I love the 100 ml bag trick. So all you do is you have a 100 ml bag of NS. You take 1 milligram of your 1 to 1,000 epi, squirt that into your 100 ml bag.
Exactly.
And now you got push dose epi. You got 100 mLs
of push dose epi. And it comes out to what, 10 mics an ml?
10 mics per ml,
Yep. So you just pull, if you need 10 mics, you pull up 1 cc. You need 20 mics, 30 mics, 40 mics, so on and so forth.
Yeah.
It's so much easier than, using your 1 to 10,000, and in the chance of an arrest or anything like that, like you still have your 1 to 10,000 right there. Now you're not having to mix that. So like, it's probably even like, to say this, I hate saying this in an economical way, it's probably the most economical way to do it too, because you got a 25-cent vial of epinephrine and a $1 bag of
a multi-dose epinephrine. Right.
Yeah.
Absolutely. I mean, and how much, I don't even know how much those are. How many?
30 mLs.
30 mLs, right?
Yeah.
You're never going to use that. You use it once, people throw it away.
Yep.
Like, open it every month.
Yeah. So, I mean, like, there's so many ways to skin that cat. And what are your thoughts on, like, you know, I was in the interview for my new job, and we talked a lot about, you know, fluid resuscitation and how there's no really backing evidence on giving 30 mLs per kilo for hypotension before starting a vasopressor. Do you like to start your vasopressors early in these situations and back it with fluid to make sure their pump's primed? Or
oh man,
that's
gosh, we could spend like 2 hours on that alone. But
there's so many parts that go.
I think that you have to be able to, I mean, start those fluids and not 250, not 500. Give them a liter. Get that thing on a pressure bag and get it going. Get it in, and while you're getting that in, mix up that norepi.
Yeah.
Get that thing ready to go, or get your push dose. We have to not be afraid to use pressors in these patients, and whether it's medical or trauma as well, right? If it's trauma, now, I mean, that leads us down a different path where if you got hypovolemia for this patient, your first product, you know that you need fluid resuscitation. If you have it, you should be doing blood. Yeah. It should be your first line.
But if you don't have it, bridge to blood, use your pressors, move on.
Gotcha. And a lot of it, I think, again, comes back to just the way that we've done things, right? Is getting them to definitive care. That's always been like diesel, treat them with diesel, get them to the hospital. So one of my favorite things that we changed, big change that came was after cardiac arrest.
Yeah.
That 10 minutes.
Oh, dude.
Oh, my gosh.
It's the best thing ever. Do you know how many patients we have, you know, either successfully resuscitated and got them to the hospital for a walkout, or not had to have rearrest in the back of an ambulance and be stuck on the side of the road waiting for, you know, a coroner or something like that? Like,
absolutely. And if you don't know what I'm talking about, after you do a cardiac arrest, right, you get ROSC, you get pulses back. Instead of throw them on a backboard and get them the heck out of here and let's go. It's cool. We got pulses, right? Now let's support these vital signs.
Let's support our perfusion.
Support that perfusion. Let's get a 12 lead. Let's hang a bag of fluid, you know, make sure it gets in, whatever it is that we're needing to do, start our pressors. Yeah. All that kind of stuff, and just see how they do over 10 minutes. See what their blood pressure is so that we can actually, again, support their vitals and just support that ROSC. So.
Yeah. I think that segues kind of pretty good into like the key components of the supportiveness of avoiding those H-bombs, because I mean, like, you know, they talk about hyperoxia in, you know, the TBI patients, and it's bad, but for a short period of time, it's not going to be the end of the planet. Like, we need to get that oxygen to the insulted area as well. I mean, like, for prolonged periods of time, you know, we'll go down that rabbit hole another time, but I mean, like we need to have that oxygen, you know, 95, 99%. Then you have to have the blood pressure to support it, because you have to have pressure to move, you know, oxygenated red blood cells from point A to point B. I mean, like,
absolutely.
The fact that it's broken down into such stupidly easy steps and we still can't figure it out some days is really mind-blowing to me. And then, you know, like, you can have a really good oxygen saturation without hyperventilating the crap out of them. And I think that's really where, you know, the hyperoxia is okay in these situations, as long as you're not blowing their CO2 off so bad that they're constricting down so far in that oxygenated blood's not getting to it.
Absolutely. And again, something that's going to help with that too is, again, making sure you have perfusion, right? Yeah. So it doesn't matter if you hyperoxygenate them, do everything you can, and they're, again, if their blood pressure is 60, that hypoperfusion is just going to make everything worse.
Yeah, so it's literally they're alive, but you're killing them faster at that point. Like, I mean, not only do they now have a secondary brain injury, now they've got a tertiary and quaternary brain injury of
Is that a word? Quaternary?
Yeah,
I like that.
I don't know how to say it. I read it on a slide a couple days ago in class, and I sat there and I had to ask the class how to say that word, and everybody looked at me and they're like, "We don't know how to say it either." I was just like, "We'll give her hell and see what happens." But there's so many things about this the epic head bleed study that is so important to our everyday care that I want everybody to really take home. Is like, not only is it good for our traumatic brain injury patients, but overall, I mean, like, they're really good general rules of thumb for our day-to-day operations. Like,
absolutely.
Supporting blood pressure. Don't be afraid to start pressors. I mean, like, I can't tell you, like, it's infuriating to me that at one point in my career, and this is learning from my own experience, that I was okay with a blood pressure of 60 or 70 systolic.
Yeah.
With a MAP of 40. I didn't even know what a MAP was when I first started, right? I mean, like, we were it means mean arterial pressure, but what does that actually mean in the grand scheme of things? I mean, like, and we were comfortable with that. We thought those were more of a stable patient when we're really actually providing harm to them. So, I mean, like, it's just those three stupid, simple things that we blow out of the water and, we suck at times.
We do. And again, it goes back to, a lot of things, but as you were talking about before, when you have like this patient we're talking about, this case study, that person's going to get intubated, stuff like that. But before we do that, again, we need to start resuscitating these patients.
Because what's going to happen as soon as you take a patient from a negative pressure breathing system to positive pressure and give them paralytics and sedatives for an RSI.
Yeah, you're going to, whatever vitals they had, you're going to knock them out, right?
You
change
lose
in their chest cavity, that pressure, right? That intrathoracic pressure, definitely going to mess with things.
Yeah.
And then anytime that you're moving somebody who's hypotensive, I mean, that stuff, blood sloshes around. It moves around, right?
Yeah.
We're big bags of, big water bags, basically.
Yeah.
So you're going to, again, see dumps in pressure. That's why every time you take a trauma patient and they're doing awesome, and then you move them over to the hospital stretcher, that their pressures crash, right?
Yeah,
just
every
that little movement.
Every single time.
Oh my gosh.
But I mean,
hate that. But, and then now you add paralytics and then sedatives on top of it.
Yeah.
Right? Now you're going to take away all that catecholamines. It's just keeping them alive.
Yeah.
Right? How many times have you seen somebody who's struggling, working hard, they get there, they go, "Oh, thank goodness you're here." And
they relax.
And they relax, and then they're gone, right?
Yeah.
Because their catecholamines just dumped. So, no, you have to, again, before you start doing those procedures, before you start moving them, unfortunately, your scene time is going to suck. But guess what? You're going to avoid some H-bombs.
Do you know the national average of an RSI scene time right now?
I don't.
Okay. So take your scene time on like a standard, like this case that we're talking about right now. It increases your scene time by 15 minutes or greater on a national average to perform an RSI.
Surprisingly longer.
Yeah. I mean, like,
should be longer.
But still, I mean, it should be. But I mean, like, if they're, 10, 15 minutes inside, then you're with that patient for 30 minutes and we haven't done anything. Like, that's embarrassing to me. Like,
it's not that you haven't done anything.
No,
right?
and I say that wrong, but like,
you can't look at, I mean, you are, again, you're setting this patient up for success.
Yeah.
Is the way we have to look at it. Is we're not failing our patients. We're not just giving them diesel,
giving
them to the hospital and say good luck.
Yeah.
Right. And just causing, again, all these H-bombs and increasing mortality. Is, you know what, we're gonna do some stuff. It's gonna seem like we're here forever,
but that's okay.
We're treating our patient.
Yeah.
Right?
We're not causing some form of, provider caused mortality.
Yeah.
Because, and it happens so frequently that it's kind of one of those little twitches in my neck that gets me when I hear these things that happen, because I learned very, very, I'm trying to think of how to say that the best way. I learned from my mistakes of not doing it.
We all do.
And
we've all done it.
We've all done it, but there's this new, the culture of, they have to be gentle, right? And like, I want to be, I mean, it's hard, right? Like, how do you approach these people and say, we need to try and do this better without, making them feel like they did a shitty job and hurting feelings.
I hate feelings.
Yeah.
I mean, that's leading me into a completely different topic. But I'm sorry, you have got to be hard. That's my favorite thing about my partner.
Mm-hmm.
She is hard as a rock.
Yeah.
Oh my gosh.
Yeah.
It sounded weird. That's my. I'm gonna say that again. I don't even know how to say that without sounding bad. But no, I mean she's the nicest person you'll ever meet. Nicest person you'll ever meet. She'll do anything for you. But if you mess up, you're gonna know about it.
She's gonna put you in your place.
And I absolutely love it.
Yeah.
Because that's what needs to happen. You don't learn if you think, oh, hey, we did a good job. It's like, actually, you killed that guy.
Yeah.
Like, the reason he arrested again, that was your fault. Sorry. Not sorry. That was your fault, and here's why.
Yeah. But you have to have that supporting backup, right? Of like being able to tell them why. And I think that, back to our younger generation, they don't know why yet. And as they learn and grow in this career.
Hell, our older generation, us. Even 3 years ago, did you know why? No, I didn't.
No. I mean, like... No, I didn't. And I'm speaking a little out on that, but I mean, like, there was a lapse in, like, knowing why these things happened. And, it's just one of those things that it doesn't necessarily keep me up at night, but I get a lot of random, text messages from across the state, it seems like, from all the people that I've interacted with that are just like, well, like, we did this, this, and this, and it just comes down to, did you resuscitate prior to your intubation attempt?
Yeah.
Like, the reason they arrested is because we didn't resuscitate prior to intubation. And I guarantee you over the next, I'm going to get into a really, crappy situation, and I'm going to screw it up at some point again too. We all do. That's why we call it practicing, right? Yes. We can't perform it at 100% all the time. But I mean, like, it's just one of those things that just... it sits there and nags me in the back of the head. And really the reason we brought this up, because this was not only was a really good case, I know we didn't talk a lot about the patient specifics. It really didn't matter. But I mean, like, we want you guys to come back and be like, maybe we should have taken that extra 5 minutes on scene to, get my line started and start getting them that liter of LR, that liter of NS, whatever you guys are carrying. Don't really care what you're carrying. LR is far superior, but that's just my thing, except in wintertime. But, I mean, like, just taking that time to sit back and let your treatment work, because we're so focused on go 100% of the time that we forget the basics.
Absolutely. And it's always, I mean, how many times we say go back to the basics or keep it simple, right?
Yeah.
But no, for sure. And unfortunately we have that. Everyone looks at your times. And I hate that, right? Because it's like, yeah, you can look at my times, and we were there for a long time. But what was the outcome of this patient?
Yeah, 100%.
Oh, they walked out? Yeah, you're welcome.
Yeah. Thank you. Like.
And there's some things, yes, they're truly surgical, and we need to go.
Yeah.
But you've got to avoid those H-bombs, especially with all your patients. Doesn't matter if it's your traumatic head injury or even, again, just a cardiac arrest. Got to get those vitals up, get that perfusion up, treat your patient appropriately.
Give them that best chance of survival and that best course of an outcome that they possibly can. Deep down inside, usually by the time we get ROSC, we're going to know, the potential outcome of the situation, right?
Correct.
Like, it's not a high likelihood that most of these people walk out unless it's a witnessed arrest and they start CPR early, or like if they get a secondary brain injury before we get on scene. Like, there's a lot of things that change these variables, but we want to do our damnedest every single time we go into this to, reduce this. And, I haven't talked about it, and this will be another conversation, but there's this really cool, it's kind of a mnemonic. It's kind of a study. There's a lot of people starting to follow it. It's called the -1A trial, and it stands for definitive airway sans hypoxia first attempt, and it's kind of how we are. Where I came from, we're setting up our RSI attempt. So they wanted us to, if they were hypotensive before we started the procedure, like that didn't knock it out of criteria. But they, they're already in a peri-arrest, so it's like we had to document, like, we have one epi, push dose epi up and ready. We're going to administer this. We're going to administer fluid. Get our patient tanked up. Get them those catecholamines back. go in for our first attempt, get their oxygen saturation up, and then so you get that definitive airway sans hypoxia. So and hypotension. So like after the attempt, we had to maintain a normal blood pressure and a normal oxygenation for up to 15 minutes for it to fall into criteria. And that really kind of helped me set my life up around my RSI, just for the fact that, this is something that we can actually like look at. We can pull data from, because data is our friend, right? Like, so if I go into this knowing that, I want to get this as a -1A airway, like I'm going to be good. Like we'll get our airway in the first attempt, hopefully.
You will.
You will. You always do it. And then you're going to get it without hypoxia and without hypotension. And those are those are set in stone that you need to do this, and you need to prevent it for 15 minutes after the attempt. And then, hopefully by that time you got your pressors and all these other things rolling. Because you're just running off a push dose for the most part right then. But it really kind of set up how I think about my airway a little bit more.
No, I think that's awesome. One of the things I like about the flight service that we didn't do on the ambulance is that QA stuff, quality and editing charts, and knowing, okay, I have this, did this chart meet this, and this? Because again, that helps you to know, okay, I have to get a blood sugar on this person. I have to get a temperature. I have to get this. So having to meet certain criteria, I think is good. The one that I don't like, again, is that time.
Yeah.
It's like we're not lollygagging. I'm making sure that we're not causing harm.
Yeah.
And again, just trying to improve patient outcomes. But just knowing that kind of stuff, and I think that's pretty cool, that study. So I wasn't a part of that one, obviously. But no, I think that's great to be able to think and say, okay, like we have got to do this stuff before. Having that make you do that kind of stuff is good. Yeah. Forcing you to do good patient care is anytime is a good thing. So.
Yeah. It put it into muscle memory more than anything. Because it's like, as I'm getting set up for like, whether this is a TBI, a trauma, a medical, or anything like that, I know that I've got my line going. I've got fluid going. I've got my pressors. I'm setting myself up for success. I've got, no DSAT. I'm nitrogen washing. I'm doing all of these things to improve my patient before I even make that first attempt. And those are all things that we know at one point in our career skipped. And, that's why we're trying to bring this to everybody, is because we want them to learn from what we had to go through as providers to get to where we are, to where we can provide this stellar care to almost all of our patients.
I think it's great. One of the things that our medical director a long time ago had us do before any innovation that we did was our procedural pause.
Yeah. Oh, I love me a procedural pause.
Adding that almost to your procedural pause is kind of good.
Yeah.
I guess a way that you could do that. So for our procedural pause, before I'm about to do an RSI or an intubation, is all right, I'm just going to stop. Yeah. Not bagging them up and everything like that. Obviously, anything that's not needing to go on is going to stop, and we're going to say, okay, this is what we have. This is what we're going to plan to do. I have this. I have a 7.0 ET2 or a 7.5. I've got this blade. It's on. It works. I've got suction on. It's in my hand. It's ready to go. I've got my bougie out, or rigid stylet. This is my backup device. Here's everything that we have. Everything's ready. Patient positioning, all the stuff, and making sure that we're not forgetting anything, making sure everybody's on the same page. We know what's going on. And I can't tell you how much that will improve your first attempt success.
Oh,
it's insane.
100%.
It's why, honestly, it's one of the reasons why I choose to intubate patients outside of the hospital more. Exactly. I know this patient's getting intubated. I would just rather do it because we're going to go through the steps. We're going to do the procedural pause. I'm going to have all my stuff ready. Yes. And I'm not going to get to the ER and it's going to be a giant cluster where they're pushing meds and they don't have their equipment right.
Yep.
Right. I wish the hospital would do it too. Some of the doctors are great at it, and it depends on what hospital you're going to, obviously. But there's some where it's just like, oh,
yeah. I walked into a hospital.
I don't have my tube. They're intubating. There's no ET tube out, or it's gone, or there's no stylet, or I hate that kind of stuff. So doing that procedural pause is huge. Yeah. So I think if you add that, I don't know what you call it.
Yeah. It's almost like it's a checklist.
Hey.
I mean, like, saying it as a checklist, I mean, like, that's just kind of a hard word for kind of us to swallow because it, it puts that stopping piece of paper in front of us. I mean, like, that procedural pause is more of my mental checklist of, do I have everything that I want? And I like the sound of procedural pause better, to be honest.
I do too. And maybe we call it that. But yeah, having that pause and being able to talk out loud too.
Yeah.
That's another huge thing because you can go through your checklist. You go through your stuff. It's just like before I go on a flight, I have my checklist. Okay, we have this, and this, and this.
Yeah.
Here's my equipment. I've got this, and this. Doors closed, all this stuff, making sure, like, again, you make sure everything's in order, everything's correct.
Yeah.
Before you take off.
Yeah.
Before you engage in the most dangerous part of your job,
Yeah.
which is either taking off or landing.
Yep.
Right? You're going to be quiet. You're going to focus on that kind of stuff. So it's the same thing for your patient. You're about to do the most dangerous thing and potentially cause harm.
Yeah.
Make sure that you have your procedural pause. You've gone through your checklist. You know what's up. Everything's on the same page. All your equipment's ready. And now we can do this procedure because we've done all this.
Did I tell you how the pre-flight checklist saved my ass the other day?
Mm-mm.
Oh, man. We were pretty set in for ground transport season, right? Like, we had all the bags down by the ambulance, like, then we just get this random break in weather, like completely random break in weather where we can fly locally and we can fly east and back to our local hospital, get paged out for a scene response. And as I'm going up towards the helipad, I'm kind of starting that checklist because I'm still getting used to the new checklist process for myself. And I'm like, equipment, bags, red, blue. And I went, they're back down at the ambulance. So I turn around. I yell at my partner. I'm just like, I gotta go get the bags. And, I mean, luckily I wasn't too far, but I ran back, grabbed the bags really quick. They finished the rest of the, pre-procedure stuff that we do. And I grabbed them and didn't delay any time. But I mean, like, it was one of those things that it saved my butt because that could have easily been one person in the back of the aircraft, getting belted in, getting buckled up, and, been an oversight.
Absolutely.
But that's why that checklist is there.
It is.
And it saved my ass.
If we had that same checklist on the ambulance, I wouldn't have left bags at patients' houses before.
My crowning jewel moment of leaving something at a house was a middle-aged male guy goes in cardiac arrest. We go there, we work on him with a little funk, and we leave. We're getting everything put back together. And I'm going, God dang it, where's my intubation kit? Like, where did that go? And I went, oh shit. So we had to drive back to the house of the guy that we just coded. Luckily, the coroners were there, to break the ice, because as we were coming back, the family was like, what are you guys kind of doing back here? And I was like, oh, we're just here to help the coroners. They asked us to come and lend a hand to completely put that blame out on there. And I was just like, okay, we're going to offer to help, and I'm going to grab that bag sitting right over there.
My best one, I left just our entire pack at the house. Sepsis guy got him to the hospital. Like, oh man, where is it? Finally, oh crap, it's at his house. So we go back to the house, knock on the door, go inside, and everyone inside. And I walk into just a room of smoke.
Oh God!
And everybody's in there just getting blitzed. I'm like, well, good thing you didn't open my narc pack in there. Hold on.
Yep.
We have that. So.
Man, that's too funny.
Breathe it in. Contact.
Oh man, that's too funny, man. But bringing it back around, kind of wrapping it up. I don't know what kind of time we're at right now, but I think we beat the dead horse enough of how important it is to resuscitate for these patients, because I love getting cases, and people that want to send cases to us, please continue to do that, and know that Absolutely. If we ever make any suggestions or anything like that, make sure that you're following your local protocol, make sure you're doing these things, and make sure you're trying to prevent that or promote that do no harm side of things, right?
Absolutely.
Because when we start working in that resuscitation prior to these big procedures and these really sick patients, it really brings into that wholesomeness of what is do no harm, and preventing iatrogenic patient death because we didn't provide something for them. So, I mean,
Absolutely.
like, we're never picking on anybody. We're just trying to get this information out. And, I just want people to have this opportunity to learn. And I think that we're going to be the ones that are able to, help out. And hopefully someday somebody will message us and be like, I really kind of took that and put it into practice, and it really helped me out at one point. So
Absolutely. And it's one of the things I love about, just jump out back here a little bit, is where we work. It's like finding these studies, doing these things, being able to promote this stuff to our medical directors, to our leadership, is in them actually being able to listen. Hopefully you're in that situation. But if you you hear this stuff, hear something new, like
like the QED innovation with the preloaded bougie, like love it.
Yeah, and being able to just take that to wherever you work, look at your protocols, say, hey, what do you guys think about this?
Yeah.
These are the studies, and this is where we're finding this information at, and take that to them and making sure that they're doing their job right. As leadership, they need to be making sure that they're staying up on patient care, stuff like that. They get busy. There's lots of meetings I know they go to and have to deal with, and a lot of BS. But again, they always want to make sure patient care forward.
Yeah.
And take this stuff to them. Make sure a lot of that, it's on us that, the providers, we're the ones out there doing the stuff. So make sure that you guys
we're reading
need something.
Studies, they're reading numbers.
That's right. Take this stuff to them and say, hey, we have got to do this.
Yeah.
We cannot be forced to have only be there for 15 minutes and you chew my ass because I was there for 25. Like, guess what? Look at the studies. Yeah. There's a reason that we need to be there longer.
Exactly. And if you don't have that, take it upon yourself. Like, promote yourself and promote an opportunity to set up something like a CPC, like a clinical practice committee, where you can, meet once a month and, go through a study and present it. Because, I mean, like, the more thought that as a provider you put into this to take it to them, the more they're going to be open to it. Like, medical directors, yes, can be scary, but they're usually harmless people that are there for the best of their patients and the best for us. So,
yeah, absolutely. Think about how you present it.
Yeah, that is very true.
That's a new.
Yeah,
we're whoever it is that's good at presenting that stuff.
Yeah,
let them do it.
Exactly.
That's why I let Sam present stuff instead of me, because everyone looks at me like, oh man, what's Isaac going to yell
held
about
the
now?
team up today because I am fried off of a fresh out of orientation, so I am on cloud 9 and full of brain mush right now. So, ladies and gentlemen, thank you so much for joining us tonight, and we appreciate you. I hope you know that. Look out for us because we'll be to something near you at some point.
Absolutely, we will. And thanks, guys.
Yeah. Oh, also, if you guys have a random, EMS world or like a EMS conference that you would like to have us come to, send us an email. Do something. Because we would love to come and do public speaking. It's one of my favorite things in the world. So that's my final thought. So
I like it. Yep, we've been looking at some places to go. So make sure you reach out, talk to us, and talk to us about anything. Got questions, comments, whatever it is, let us know. Thank you guys.
Once again.
And we'll see you on the next one.
And stand by for tones.
That's right. Stand by for tones. We'll see you on the next one.